Mr. Chairman, ladies and gentlemen, dear colleagues, it's my distinct pleasure to discuss with you the anticoagulation strategies in Garfield VTE. The main focus will be on the initial treatment, but we will also see the pattern up to 6 months of therapy. These are my disclosures. And just to set the scene, I would like to go back and briefly repeat what are the different, or the three disease phases. We have the acute phase of the disease, the intermediate and long-term phase of the disease, and accordingly, we have also standard of care anticoagulation, and I think everybody in the room is well familiar what means standard anticoagulation therapy so far, because it has been in place for half a century or even longer. Standard anticoagulation therapy comprises both overlapping treatment with parenteral therapy and vitamin K antagonist, and I think the reason why we need this package is also known to everybody in the room. The reason indeed is because of the slow onset of action of vitamin K antagonist. We need to protect the patients immediately, and that is done by the parenteral anticoagulation therapies. Meanwhile, we have 4 direct oral anticoagulants available, 3 10A inhibitors, such as rivaroxaban, apixaban, and edoxaban, and 1 thrombin inhibitor, such as dabigatran. And there are slight differences between the regimens, but also differences between the strategies, because 2 of them, and that is true for dabigatran and edoxaban, require routine parenteral anticoagulation therapy first before the maintenance dose of the DOAC is given, whereas rivaroxaban and apixaban had been developed as monotherapies, that means with intensified treatments in the beginning to mimic heparin treatment therapy, followed by the maintenance dose over time. The aim of this presentation is to describe initial and longer-term anticoagulation therapy, particularly different patterns, of patients prospectively enrolled in Garfield VTE from May 2014 to January 2017. You saw this diagram earlier. Lord Kecker had shown it already, but in his presentation, he ended with this text box pointing out that we have enrolled 10,677 patients with an objectively confirmed diagnosis of VTE. I would like to lead you one line below and focus on a subset of these patients, the so-called anticoagulation-only treated patients, and this includes a subgroup of 9,111 patients. And I will mainly focus on the initial treatment period, which includes also the period before diagnosis, because we have quite a few patients who got treatment upon suspicion, because diagnosis is not everywhere available same day, or even next day, or over the weekend. So we focused on these patients, including also the pre-diagnosis period, to purely reflect anticoagulation treatment patterns. These are the 5 categories of anticoagulants: the parenteral therapies only, parenteral overlapping with VKA, parenteral followed by the DOACs, DOACs only, and also a small group of more than 5% of patients who received vitamin K antagonists only, although we won't find this group in the guidelines, but in real life we find it. On the right side, you see the split of the parenterals as expected, highest percentage of the low moles, followed by unfractionated heparin and fondaparinux. Well, you also saw on one slide of Lord Kecker that Garfield VTE followed a staggered enrollment approach, and that's why I divided these two groups into the time periods of 2014 to 2015, and on the right side, 2016 to 2017, to reflect what happened within these time periods. You can easily see that there is a slight different pattern. It's less than we expected. However, there is a slight different pattern because in the first period, we had higher percentage of standard of care patients with parenteral overlapping with VKA, and we lost 4.3% of these patients in the second period, and vice versa. We had more uptake of the DOACs only seen here up to another 4.6% in the second period of time. It's less than expected. However, we need to say that that Garfield VTE started when already the DOACs had full momentum in many countries participating in this registry. This is showing the split of initial anticoagulation patterns by geographic regions. Again, geographic differences and variations. A nice split in Europe between parenteral or conservative anticoagulation therapy and parenteral followed by DOACs and DOACs alone. In Asia, the DOACs alone have the highest percentage. In North America, the highest percentage was parenteral anticoagulants followed by the DOACs. And in other countries, the highest percentage was standard of care. However, in other countries, spelled out here in the lower line, there is quite a high percentage who got vitamin K antagonists only without parenterals overlapping or before. If we split down the initial anticoagulation treatment patterns by VTE site, you can easily see on the left side that PE patients, PE plus minus deep vein thrombosis, had a higher chance to be treated with parenterals followed by DOACs, higher percentage here when compared to DVT alone, almost 34% here and almost 20% only when the patients had only DVT, and vice versa. About 19% of the patients had DOAC alone when they had a PE, and thus this went up to 30% when PE and when they had DVT alone. So this is vice versa, but again, as expected, and I think there is no further comment needed for this. Interesting to see how the patients were treated if they had not yet had a confirmed diagnosis. The patients who had not yet had a confirmed diagnosis before diagnosis had much higher chance to get parenteral anticoagulation only when compared to the patients who received their treatment after diagnosis. And what you also can see, and I think that is a finding which needs to be commented on in those countries where they may frequently have this practice, that before diagnosis, however, upon suspicion of VTE, they were treated with VKA only. And this was a different pattern if we follow the treatment patterns after diagnosis, but more than 10% of patients with VKA only, with a strong suspicion of VTE, is, I think, not the best way to treat the patients, and we will follow up if there is a specific reason behind, because, as you know, this will put the patient at a prothrombotic state, although they have already have their clot in the body. Fortunately, some of these patients could perhaps also then not be confirmed by the thrombosis, by the diagnosis. And this leads us into the longer-term follow-up period from initial treatment therapy up to 3-month and 6-month period. On the left side, again, the peri-diagnostic period where we had the broad variety of standard of care and also the 2 different strategies of DOAC use. but after 3 months of diagnosis, we have a completely different pattern. That means, as expected, we have a significantly higher percentage of DOAC patients only after 3 months, and we also have market uptake of VKA only, as expected, because that is not only the initial treatment period only. This is the initial treatment period. However, here we are in the maintenance phase of treatment already, and the same picture is maintained up to 6 months. And why we don't have a steeper increase of the DOAC is because we lost quite a few patients over time, fortunately, because the doctor had decided, hopefully for good reasons, to stop anticoagulation therapy. These are the patients here, and more patients after 6 months, but unfortunately also because we lost patients because they died. But there is the bottom line that, as expected, we have a marked increase of DOAC strategies in the maintenance phase of treatment. This leads me to the conclusion saying that there are geographic variations of anticoagulation treatment patterns may reflect the cultural differences, but also, of course, reimbursement of DOACs. The variation of anticoagulation treatment patterns over time, and I'm talking here about the 2 time periods, 2014 versus 2014-15 versus 16 and 17, is less than originally expected because momentum in DOACs prescribing had already taken hold when Garfield had started. A higher percentage of parenteral and DOAC is prescribed in patients with PE than in patients with DVT only, and vice versa. We have higher percentage, as already mentioned, in the DVT patients only for the DOACs only when compared to the PE patients. And I think we also observed a clear shift from conventional parenteral and VKA treatment in the first 30 days towards DOACs in the following 5 months. And this leads us with the question if the DOACs have become new standard of care for chronic anticoagulation. Thank you very much for listening.